Hello, everyone. Welcome to Chapter 9. So we're going to do this in one go. There's a chapter we're going to do next I would like to have three parts on. So I'm going to do this chapter the first half of the week and do another chapter second half of the week. So this deals with articulations. I chose a quote that the only place where success comes before work is in the dictionary. So what we're going to be talking about is this really simple chapter, really not too bad of a chapter, so we'll be talking about it. So as we go on, we just want to really remind you guys, first off, that what a joint is, what an articulation is where two bones meet. Now, this is the place that movement can happen. Movement can only happen at a joint. Structure of a joint determines what it can do. It determines its movement. So it's a very important relationship between form and function, like I talked about in chapter 1. How form fits function. There is this, we will see it on display here. Now, structure of a joint determines what it can do. Form fits function. Now, with that, there's a really good balancing act. Now, if I kind of looked at it, and I looked at structure and I looked at function, and I looked at strength and I looked at movement, and I looked at these kinds of things, we'll see it all fits together. And the analogy I might kind of give is saying that if I had to go and haul some mulch to somebody, I would get my old pickup truck. I would get my Silverado. If I was going out for a fun night on the town, I would take my Challenger. I'm not going to take my pickup truck out. It's not as nice. So I'm going to take my nice sports car, a muscle car out. Now, if we kind of look at the same kind of thing, structure determines function, we're going to see that. Now, what we're also going to see is this balance and strength and movement. And basically what you will see is, and this is reflected in that, is the stronger a joint is, what you're going to see is the less it moves. So what you are seeing here is we're sacrificing movement for strength. And the weaker a joint is, the more it moves, that we're basically sacrificing strength for mobility. Okay, so a stronger joint is, less it moves, the weaker the joint, the more it moves. And what you basically will see is you're basically a trade-off between strength and mobility is trade-offs between those two things. Okay. Now, what we're going to see, we're going to start classifying joints. And what we're going to do to classify them is we're going to look at them based on two things. We're going to look at them based on anatomy, and we're going to look at them based on movement. We're going to look at them structurally, and we're going to look at them functionally. We're going to look at them based on the anatomy, and we're going to look at them based on the movement or range of motion. So structurally, functionally, that's what you're talking about. Now, there are relationships between the two, as we just said. Basically, what you'll see is when you have a structural joint, if it structurally doesn't allow very much motion, then we're going to see it very strong, for example. So we're going to see that anatomy will dictate the kind of motion that it has. Structure of a joint is going to dictate the function of the joint. So we're going to see these two really are related pretty well. Now, what I'm going to begin with here is, let me make sure I did. Okay, good. And let's really begin with the anatomy. And we're going to begin based on classifying them on anatomy. We're going to start with fibrous, cartilaginous, bony, and synovial joints. Now, what is a fibrous joint? These are going to have fibrous proteins between the bones. For example, how fibrous proteins fill up the sutures of the skull. We're going to see cartilaginous joints. There's going to be some kind of cartilage, what we saw with the pubic symphysis, what we saw with the vertebrae, the intervertebral joints. We're going to see bony joints. This is where bone fills in the space. We're going to see that we saw this when we did osseous tissue, when we saw the growth plates close up and they fill up. And synovial joints, synovial fluid. We're going to see the ends of long bones have synovial joints, synovial fluid in them. Okay. Now we're going to see based on the range of motion, based on the classification of range of motion. If we have no range of motion, we're going to say it's an immovable joint. We're going to say it's a synarthrosis. Syn meaning together, arthros meaning joint. Synarthrosis, a together, fused together joint. The joint is jammed together. It is immobile. And amphiarthrosis, amphi means both sides. You probably, or best of both worlds, so to speak. You've probably seen this most famously in the word amphibian. Okay. And amphiarthrosis is basically a slightly movable or somewhat mobile joint, okay? And diarthrosis, they are freely mobile. They are quite mobile. They're freely mobile joints, okay? So what we're going to take is these words and break them down. So make sure you're doing that. Now, we're going to start with our synarthrosis, our amphiarthrosis, and diarthroses, and we're going to say, okay, these things are related. A synarthrosis could be a sutural joint, a gomphosis, a synchondrosis, or a synostosis. An amphiarthrosis could be a syndesmosis or symphysis, and a diarthrosis may be a synovial joint, okay? We're going to talk about these. So what is a synarthrosis? We remember that is an immobile joint. So suture joints, the sutures in the skull, are not mobile. They are not going to move. Found only between the sutures in the skull is a sutural joint. A gomphosis, gomphos means bolt. This is where the teeth lock in like a bolt riveted into a hole. A synchondrosis, syn together, chondro cartilage. This is going to be a non-mobile joint with cartilage. Now, synchondrosis, very important here, is this is hyaline cartilage is involved, okay? Now, it's between the sternum and ribs. Synostosis is a bony fusion. These are when two bones fuse together, like what happens at your growth plates or what happened in the skull. There was a suture in the frontal. There were two frontal bones that we had, and a medtopic suture down the middle of it, and it filled in with bone, became a bony fusion. Amphiarthrosis, somewhat mobile. Syndesmosis, this is somewhat mobile, but we have ligamentous attachment. Symphysis is a cartilage, but it's fibrous cartilage in a symphysis, like with the pubic symphysis, with the intervertebral joints. Okay. Diarthrosis, this is going to be a wide range of motion. This is going to be your synovial joints at ends of long bones. Okay. So here we can see a sutural joint, a gomphosis, a synchondrosis, and a synostosis, and these are all types of synarthroses with no movement. Then we can see our amphiarthroses, somewhat syndesmosis or symphysis joints, and then we can see that there are the freely mobile diarthroses with the synovial joint. And we'll take a look at monaxial, biaxial, triaxial planes of movement in a little bit. Now, as we're talking about synovial joints and being diarthroses, being freely mobile, what we want to do is look at our two-layered thing that surrounds this, called a joint capsule. Joint capsule or articular capsule is part of the outside of the joint, where it's got the synovial membrane on the inside and a fibrous capsule on the outside, so it's two layers. Now, the synovial membrane inside holds the synovial fluid. So that's one thing. It is an articular capsule that's on the outside made up of, so let's talk about the synovial membrane containing the synovial fluid because I want to mention it again. And then we're going to talk about the articular cartilage or hyaline cartilage that is found there. Now, the synovial fluid, basically, fluid cannot be compressed, so it prevents articular cartilages of the bone from making contact, and it also acts as a lubricant. So it prevents bone-on-bone contact and lubricates the joints, okay? It puts some juice in the joints, so to speak, okay? One of the ways I like to kind of say it is add some juice to the joints. Okay, so we're going to see that we have our capsule here, our joint capsule, which has the synovial membrane on the inside. Okay, that contains synovial fluid. There's articular cartilages on the end. It could be more complex if we look at something like a knee joint, where we're going to have other things like bursa sacs and menisci and a variety of other things going on there. Okay. Now, synovial fluid, very rich in proteoglycans and hyaluronic acid. It's going to be a lubricant. One of the big things, reduces friction between articulated bones. It's going to act as a nutrient distribution. So what's going to happen is it provides nutrients to the articular cartilage because it is avascular tissue. And it's going to be a shock absorber. It's going to cushion any places where compression is happening. Now, another big thing that we're going to be able to see is when the joint moves, when you get joints to move, the movement of the joint aids the movement of synovial fluid, which is important for joint health. Basically, we got to keep our joints moving to keep them healthy. One of the things I always kind of say is what you're doing is you're juicing the joints, okay, where we're getting that mobility, keeping that mobility going, okay? Now, one of the things we're going to see about our synovial joints is there will be structures that assist, structures that are accessory to the synovial membrane and the articular cartilage and things like that, the articular cartilage and the joint capsule and things like that. So we're going to see our cartilages that are also there, for example, like the meniscus, the menisci that are inside the knee, for example, between the articular surfaces, fibrous cartilage pads that are between the knee, fat pads that might be there, masses of adipose that help protect, cushion, shock, things like that. We're going to see ligaments that connect bone to bone, ligament, bone to bone, and it's going to help stabilize bones. It's going to help stabilize joints. They may be extracapsular on the outside of a joint, or they may be intracapsular on the inside of the joint capsule. Sometimes they're on the outside of a joint capsule, sometimes they're on the inside of a joint capsule. Tendons, they can be attaching muscle to bone. For example, they also create stability. And there are bursa sacs, which are these little cartilage pouches that are full of synovial fluid, and they help cushion tendons and things and ligaments and things like that to reduce friction there. Okay. All right. Now what we're going to see is what that rule coming back we talked about is that if you have a joint and this joint is very mobile, then by definition it's weaker. And if you have a joint that's not mobile, by definition it's stronger. The greater the range of motion, the weaker the joint. The weaker the joint, the more prone to dislocation it is. And we got some problems there. We got dislocation. Now, so what we want to do is not let this happen if we can. We want to try to stabilize it. We want to make sure this joint can keep its stability. And how we can do that is we can add things like collagen fibers of the joint capsule. We can take ligaments and tendons, and those collagen fibers of these structures will go in and give extra strength. Then what we could do is take cartilages like the menisci and things like that and stabilize the joint as well. We can use other bones. For example, the fibula comes in and helps stabilize the knee joint. We have muscles, the quadriceps, the hamstring, the things like that. And we're going to see fat pads, other things like that, other bones, muscles, and fat pads will come in. Then when the muscles actually pull on their tendons, that will create a tension that increases stability as well. Okay, this is one of the reasons why we send people to physical therapy after a knee injury to tighten this stuff up to increase the strength and stability of that joint when it's been damaged. Okay, the collagen has been stretched out. The collagen fibers have been stretched out. All right, now we can damage a joint, so joints can get damaged, and so we talked about that if they are very mobile, they're more prone to dislocation. Dislocation is when you take a joint and you force it out of position, okay? This is called a dislocation or a sublux or a luxation. I apologize. A dislocation or a luxation. Subluxation is a partial dislocation, okay? This is kind of out of alignment and things like that, okay? Now, what we're going to see is we're going to look at movements, we're going to look at plane and direction, and we're going to look at the relationship between other structures. So plane or direction of motion, monaxial, biaxial, triaxial, relationship between other joints. Does it move away from? Does it move towards? Does it reduce the angle? Does it increase the angle? Does it move in front of something? Does it move behind something? Does it move around it? How does it move associated to other structures? And we'll talk about those kinds of motions as well. So we're going to start out with kind of motions, and we're talking about linear dynamics, and we'll basically talk about the types of dynamic motions, and we're going to go into linear movement, gliding, kind of like what happens when you take a mortar and pestle and you glide the pestle against the mortar. The angular movement, things, for example, when you flex your arm, things like that, when you bend your knees. Rotation, when you look to the left, look to the right, when you spin your hips, when you twist your hip, twist your lower back, for example, rather twist at your hip, twist to the side. Now, basically, we have three planes, three axes, X, Y, and Z, basically. Okay. If you have one plane of motion, we call this monaxial motion. If we have two planes of motion, then it moves in two axes. We call this biaxial. And if it's three planes of motion, we call it triaxial. So monaxial, biaxial, triaxial. Okay. Now, joint movement can be very dynamic, and we're going to get into some of these, but there are some examples of gliding motions and angular motions and rotating motions and all that. Now, What happens is in gliding movement, we have the they slide or glide past each other. For example, at the vertebrae, one vertebrae above the other vertebrae, they slide on each other. Your carpal bones, your tarsal bones, they slide on each other. Your clavicle and your sternum, it slides. Very slight movement because there's ligaments and joint capsules attaching it. It's limited. It wiggles some, it gives a little bit, but not very high motion. Now, angular motions, which are angular, they can be flexion, extension, hyperextension, adduction, or abduction. Now, flexion, extension we'll take together. Flexion is the reduction of the angle between two articulating bones. So if I hold my arm out straight at 180 degrees and I flex it, I'm going to make it towards 90 degrees, 45 degrees. I'm going to reduce the angle. If I do extension, if I have my arm fully flexed and I extend it out to hand somebody something, extension increases the angle. Okay, so it might go from a 45, 90 to 180. Now, hyperextension is extension past anatomical position. For example, with hyperextension, if you look straight up into the sky, you would be hyperextending the neck. If you take your hip and push it behind you, you're hyperextending the hip. Adduction, that is movement towards the midline of the body. Movement 2, you add to the midline. Abduct, abduction, movement away from midline, like somebody has been abducted, they've been taken away from the midline, okay? So here you can actually see the, for example, we flex when we look down at our feet, we extend when we put the head back up, and hyperextend when we look up into the air. We flex when we flex our elbow, we extend. Hyperextending the elbow is very hard. Now we can flex the leg by putting the leg forward, extend it by putting it back to the ground, hyperextend it from sticking it behind us. Okay, we can adduct by moving towards the midline, and we can abduct by moving away from the midline. Adduction, abduction, adduction, abduction. Okay, we can also abduct our wrists. Now, we're going to talk about some other motions like circumduction in a minute. Okay. Now, rotational motions, circumduction, that's one we have. Now, in circumduction, we move the distal end of the bone, we make a circle, but the shaft doesn't rotate. So the shaft isn't turning like a drill bit. What happens is, in circumduction, you have movements in the proximal end that makes the distal end draw a circle in the air. But there's no rotation of the arm or no rotation of the leg or the finger. Like if you take your finger, your index finger, and draw a circle in the air with it, that's circumduction. Rotation is pivot on an axis, left or right. Like you look left, you look right with your head rotates. Medial or internal rotations where the anterior surface of a limb turns towards a long axis. Like if I were to bring my shoulder forward towards moving it in towards my pecs. Okay, lateral rotation or outward rotation is when I'm going to take my shoulder and move it away. I'm going to pull it out like I'm reaching behind me. Okay. Pronation and supination have to do with the forearm. The forearm turns palm down, that is pronation, palm down. Supination, palm up, okay, up or anteriorly. Palm down, posteriorly, palm down, or posteriorly, pronation. Supination, palm up or anteriorly, okay? So you can see I can rotate left and right, okay? At the atlantoaxial joint, I can have an internal rotation or lateral rotation. Internal rotation, lateral rotation, okay? Supination, pronation, when I take my forearm and I rotate it, okay? Now, other special movements, inversion, eversion. Inversion turns our foot inward, like when our foot twists in, okay? Eversion, our foot twists out. Lateral flexion, like if I take my neck and bend it to one side, or the other side, if I go, I don't know. Or when I bend towards the side, like if I do a back stretch and I stretch to the side, I take my whole torso and bend it to the left, bend it to the right, things like that. Plantar flexion and dorsiflexion have to do with the toes being pointed, our foot. Plantar flexion is used, like, for example, if I'm in my car and I plant the pedal to the metal. If I push the gas pedal down in my car and I take off, I'm plantar flexing on the gas pedal. If I pass a police officer and I think they might have seen me speeding and I let off the gas, I've dorsiflexed. I pulled off the gas, let off the gas, and slowed my car down. Dorsiflexion. Dorsiflexion is going to pull the toes upwards towards the shin. Okay. Now, opposition, that's when you take your thumb and touch it to your other fingers or towards your palm. Elevation, like when I bite down, if you bite down really hard, if you bite down with your teeth, that's elevation. Your mandible has been elevated, moved upwards. Depression, if your jaws drop from being shocked, you are depressing. Protraction, a good way to protract is when you move your jaw forward. Like if you push your jaw forward like you have a bad protruding jaw, like I always make a joke about the guy from Family Guy, Sir Reginald Bottomtooth IV. So, yes, Reginald Bottomtooth. I always make that joke in my lecture. But I always do these things in lecture. My students always crack up when I do the protraction and stick my jaw out. Then retraction. I kind of have a weak chin, and I always make a joke about my weak chin. And I said my weak chin, if I retract it, you can't tell that I have a chin. I become the chinless wonder. So my retraction, you would pull back the jaw, and it would pull backwards, and your mandible would slide back. Okay. Now, so that's a good example of that. So eversion, inversion, dorsiflexion, plantar flexion, opposition, retraction, protraction of the jaw, depression, elevation, lateral flexion, bending your head and neck. Okay. All right. Now, movements, they can be a variety of things. They can be functionally classified at synovial joints as being gliding. That's where a flat and curved surface with limited motion, monaxial, like at the vertebrae, but still synovial joint, just not a lot of movement at the synovial joint. It could be hinge, angular motion, monaxial, flexion and extension, only moving in one axis, like the only moving in the y-axis, only moving in the x-axis, only moving in the z-axis. It's going to be like the elbow and knee. Pivot joint, rotational only, monaxial. The example of this is going to be atlantoaxial joint. That's when the atlas axis where your head pivots. A condylar joint, an oval face with a depression, allows two planes. Biaxial. A saddle. This is a biaxial where we have two concave surfaces that straddle each other. Biaxial. And ball and socket. Ball and socket are round with a ball in a depression face, like your shoulder and hip. And these are triaxial, okay? They can move X, Y, and Z directions, okay? Now we're going to get into the part where we deal with the actual joints, okay? We're actually going to be dealing with the anatomical joints for the rest of this lecture, and we're going to be getting into just those. So that first half is pretty easy, just a bunch of definitions. Now, the anatomy part, also pretty easy. Now, one of the things I'm going to ask you guys to do is be able to basically take anatomical bits and make sure that you know what joint they are associated to. Like, if I mention a ligament, what joint has that ligament in it? That kind of stuff, okay? Now, so vertebral articulations, they're going to involve one vertebrae on the top, one vertebrae below, articulating gliding. Now, this gliding allows flexion and extension, lateral flexion, and some rotation to happen. Now, normal intervertebral articulations go from C2 to sacrum. And that's where your intervertebral disc will be. Now, between C1 and skull, there is not one. Between C2 to sacrum, every one of these have an intervertebral disc. Now, the intervertebral disc, think about it like a Reese's cup. If you get a Reese's cup, the candy Reese's cup. In a Reese's cup, we have the wrapper on the outside, that brown wrapper that you peel off. Then there's the layer of chocolate and the inner layer of peanut butter. Now, the outer layer here, we're going to basically talk about the annulus fibrosus is going to be the chocolate, like the chocolate on your Reese's cup, my favorite candy. when I tell my students it's my favorite candy, sometimes they'll bring it to me on the exam day. They'll bring me Reese cups. The nucleus pulposus, this is the soft gelatinous core, enables shock absorption. And then and that's going to be your peanut butter. Then the brown wrapper is the vertebral end plates, a thin covering of hyaline cartilage that's on the outside. Okay, annulus fibrosus is the tough fibrous cartilage. That's the chocolate. The nucleus pulposus, that is the peanut butter core. And then the little brown wrapper that's on it is the vertebral end plate. Okay. Now, the first articulation that we see, that we name, is called the atlantoaxial joint. It is a joint where C1 and C2 meet. It's a pivot joint, rotational motion that is allowed. Now, sometimes the dens breaks and we get what is called a hangman's fracture, where that's broken. To image this, you got to go through the mouth to get the image, okay, in clinical practice. We want to get that sometimes. Somebody may have had a motorcycle crash, something like that. Sometimes we'll check, see if they got a hangman's fracture. It's called that because they put the knot of the noose under the chin so that it snaps the neck, breaks the dens, and basically takes your brain stem like a stalk of celery and just snaps it. Okay. All right. Now, vertebra have ligaments, okay? So one thing I'm going to say is, guys, that we should pretty much always, when it comes to vertebrae, we should call them vertebros because they always got your back, okay? Now, the vertebrae, what we're going to do is we're going to see these ligaments. Now, there's an anterior longitudinal ligament, and the anterior longitudinal ligament runs on the anterior surface of your vertebral bodies. So they're on the front of the vertebral bodies. Posterior longitudinal ligament runs on the back side of the vertebral bodies, the posterior surface. Now, the posterior longitudinal ligament is kind of thinner. So a lot of times if you have very bad posture and you sit hunched over, hunch a lot, you're going to be putting a lot of force on that posterior longitudinal ligament, and it's not as thick and as strong to handle that. Now, we're also going to see ligamentum flavum, and they're going to connect the lamina with adjacent vertebrae. They're going to connect lamina of the different vertebrae. Interspinous ligaments are on the lateral side of the spinous processes. Supraspinous ligaments are on the tip. They start at C7 and go down to the sacrum. And from C7 to the skull up, we have what is called the nuchal ligament or ligamentum nuchae. I learned it as nuchal ligament, so I'm usually going to say nuchal ligament from default because that's how I learned it as a student. Our book kind of says ligamentum nuchae. I honestly prefer nuchal ligament myself. That's how I'm going to usually say it first because that's how I learned it as a student. So you can see that much bigger, thicker anterior longitudinal ligament, the thinner, weaker posterior longitudinal ligament. We could see the ligamentum flava. We could see the supraspinous ligament and the interspinous ligament. Okay? All right, now let's talk about some things that can happen to your discs. One of the things that can happen is you get a bulging disc. We sometimes call that a slipped disc. So somebody gets a slipped disc, daddy or grandpa. Somebody, maybe they worked really hard in their life. They get a slipped disc from hard manual labor in their whole life. The annulus fibrosus of the disc is actually forced out between the vertebrae, so it actually kind of bulges out a little bit. The annulus fibrosus kind of forces out between the vertebrae and bulges. Now, when this nucleus pulposus breaks through the annulus fibrosus, we say the disc has become herniated. Now, one thing that can happen is this herniation can get worse enough where it bakes and travels into the spinal cord, and now we call it sequestered. We now say it is sequestered, okay? All right, now let's get into another big joint. Let's talk about the shoulder joint. The shoulder is actually two joints. There's our glenohumeral joint and our acromioclavicular joint. Now, the glenohumeral occurs between the glenoid fossa of the scapula and the head of the humerus. The acromioclavicular happens when the acromion and the clavicle articulate. Okay, the acromion of the scapula and the clavicle. Okay. All right, now the glenohumeral is by far the most important. It is the big one, okay? Now, this is the most mobile joint in the body. Now, remember, it's the most mobile, so it's the weakest. It's the most prone to dislocate, Okay, it is a triaxial, all three axes of motion, X, Y, and Z, ball and socket, diarthrosis. The head of the humerus articulates with the glenoid fossa of the scapula. Now, to take our glenoid fossa and make it a little bit bigger, we increase the surface area and enlarge the glenoid fossa by taking a ring of fibrous cartilage around the glenoid fossa called the glenoid labrum, and it deepens the socket. This glenoid labrum sometimes tears. We get a labral tear, a glenoid labrum. Now, most of the stability here comes from the rotator cuff. The rotator cuff is the most important for stability. Okay, so rotator cuff gives us most of the stability here. Remember the sits muscles. It's supraspinatus, infraspinatus, teres minor, and subscapularis. Remember minor. Why I say this is always because there's a teres major that we're going to learn. The teres minor, it is a minor injury. Okay, it is a minor injury to tear your rotator cuff. Not a major. It's not life-threatening. Okay, it may hurt, but it's not a major injury. Okay, you're not going to die from it. Now, an acromioclavicular joint, non-axial, no axis that it moves in, gliding, diarthrosis. Okay, it's just a wiggle. Okay, it's a wiggle joint. Glenohumeral. Okay, so this means the glenoid to the humerus is one of the ligaments. Now, these are easy to remember. They tell you exactly what they attach to. Glenohumeral, glenoid to humerus. Coracohumeral, coracoid to humerus. Coracoacromial, coracoid to acromion. Coracoclavicular, coracoid to clavicle. Acromioclavicular, acromion to clavicle. Pretty easy to remember these, okay? Cool. All right, so here's some of the anatomy, and you can see some of these structures we're talking about, okay? I don't spend too much time because, I'm not going to expect you guys to be able to identify them. Now, the elbow is a hinge joint. Now, we say it's a complex hinge joint because there are some other motions other than just hinge motions that happen. The strongest joint is the humeral ulnar, and that's where the trochlea, I almost said trachea. I taught respiratory today in A&P2, so trachea was in my head. I apologize. The trochlea. The trochlea of your humerus is going to go to the trochlear notch of the ulna. Okay, trochlear notch of the ulna is going to be on the trochlea of the humerus. Sometimes called the semilunar notch. Now, what's going to happen is there's a humeral radial joint as well. The head of the radius articulates with the humerus. Elbow does flexion and extension, but also supination and pronation. Okay. Now, there are three ligaments here in the elbow that I want you to know. The radial collateral ligament, radius is on the lateral side, so this stabilizes the lateral side of the elbow. Ulnar collateral ligament, ulna is on the medial side, so it stabilizes the medial side of the elbow. Now, the annular ligament, think something comes around annually. Okay, it comes around annually. It comes around. Annular wraps around. Okay, it wraps around. Okay. So, all right, annular. Now, the hip joint. The hip joint, sometimes called the coxal joint. I like to say when you're young, you go to new hip joints, and when you're old, you need new hip joints. Okay, it's a triaxial ball and socket diarthrosis. Okay, flexion, extension, hyperextension, adduction, abduction, circumduction, rotation, all can happen here. Okay, what's going to happen is our head of the femur goes to the acetabulum. Now, associated here, there is in the acetabulum an articular cartilage shaped like a horseshoe or a toilet seat. Okay, the acetabular labrum, like there was a glenoid labrum, goes around and increases the depth of the acetabulum. There's also a transverse acetabular ligament. When you take the horseshoe, there's a gap at the bottom of the horseshoe. There's a gap at the bottom of the toilet seat. That gap, called the acetabular notch, has a transverse acetabular ligament going across. And then there's a ligament ephemeral head, sometimes called ligamentum teres. Teres means round or smooth. This starts at the transverse acetabular ligament, goes up and goes to the fovea capitis of the femur. Okay? So right here we can see this articular cartilage shaped like a horseshoe or a toilet seat. We could see the labrum around that. We could see the acetabular notch with a transverse acetabular ligament spanning that. Coming from the acetabular notch, we have the ligament femoral head coming up here. Okay. All right. Now, in the hip, there is iliofemoral, pubofemoral, and ischiofemoral ligaments. Now, these ligaments add extra strength. They are very strong. One of the things they used to do to people back in the day is they would do something called draw and quarter. And what they would do is they take each arm, tie it to a horse, each leg, tie it to a horse, slap the horses, and the horses would go in separate directions and pull you apart. And sometimes the hip just wouldn't come apart. And they would actually have to take an axe and hack the hip so it would come apart. Because these ligaments are that strong. They're pretty strong. So iliofemoral goes from the ilium to the femur. Pubofemoral goes from the pumice to the femur. And ischiofemoral goes from the ischium or ischium to the femur. Okay. Now, in the knee joint, this is monaxial, one axis, generally speaking. There is a little bit of rotation, very minor amount of rotation. That's so minor, it's not an integral part of the function, so we're going to functionally refer to this as monaxial. Femur and the tibia articulate. There is some minor articulation with the patella on the femur. That's a non-axial gliding diarthrosis that I don't worry too much about. I'm really focusing for the anatomy. We're going to focus on the knee joint. That is the hinge joint. Okay. Now, in the knee, one of the things that happens is your hip passes all the weight down the femur, passes it to the knee, and basically down the leg, down to the tibia. So there's a lot of weight being passed down there. Now, the knee joint does flexion and extension, but there's a minor amount of rotation that happens, and it's kind of important to talk about, but not important enough to like dictate that it's anything other than monaxial. Now, what we're going to see is the knee joint has three articulations. There's a medial femoral condyle and a lateral femoral condyle. Those are the two most important of the two femoral condyles to the tibia. Now, the patella and the knee surface as well is another articulation, but the big one that we really want to talk about is the medial and lateral femoral condyles to the tibia. Now, there are two condyles of the tibia with two menisci, the medial meniscus and lateral meniscus. They are going to be cushions. They're going to help when the knee changes its shape, when the knee flexes, when the knee extends. These conform to the shape. They get squeezed on. They get, excuse me, I sneezed, and they extend. Okay. Now, they also give lateral stability. Knee can get hit from the side and get pushed in. This is things we got to worry about with football players getting knee injuries and things like that. All right, ligaments in the knee that we need to know. First off, we're going to start with our patellar ligament. That's where the quadriceps muscle goes on, and then we have our patellar ligament. Okay, so it's basically a continuation from the quadriceps. Now, there's the two popliteal ligaments on the back of the knee. The popliteal is the underknee. Inside the joint, there's the ACL and the PCL, the anterior cruciate ligament and the posterior cruciate ligament. Now, cruciate, you may recognize this, cruciate from like excruciating and things like that. Cruciate references the cross, okay? The cross. Excruciatos, out of the cross, excruciating, where we get the name, basically the name for, one of the most worst pains you can feel is actually borrowed from crucifixion. Okay, so the anterior cruciate ligament, ACL and PCL, cross each other like an X, and they prevent an anterior posterior movement. I don't worry about which one does anterior, which one does posterior at this level. I'll worry when you guys have to do more on musculoskeletal stuff. But really important here is that they cross and they prevent anterior posterior movement so the knee doesn't get jammed. So if the knee hyperextends, you could tear essentially ACL injuries, kind of common. Basically, the three common is your ACL, your MCL, and your medial meniscus. That's your three most common injuries of a knee. The tibial collateral ligament, which is called the medial collateral ligament, the MCL, that's a commonly torn, called tibial collateral ligament. It stabilizes medial side. And the fibular collateral ligament, also called the lateral collateral ligament, stabilizes the lateral side of the knee. But they do this when they're in full extension. So if you are hit in full extension, you're going to have the most amount of stability. Knee is less stable if it's not fully extended. Okay. So what we're going to see is your ACL, PCL, your ACL, your anterior cruciate ligament, and your PCL. And they cross each other. They form an X, okay? There's a meniscus, a lateral meniscus, and a medial meniscus between the femoral condyles. Your popliteal ligaments on the back, your patellar ligament from your patella down, continuation from the quadriceps standing down. Your collateral ligaments, we have our tibial collateral ligament and our fibular collateral ligament. Okay. All right. Now, diseases that won't be on the test, but I'm going to talk about them. Any disease of a joint, we call it arthritis. Rheumatism is a pain or stiffness of a joint. Rheumatoid arthritis is an autoimmune disease that attacks the joints. Gout is when uric acid crystals build up in the joint. Osteoarthritis is wear and tear of your articular cartilage. Gout, eating purine-rich foods increases risk of gout, gouty arthritis. So we sometimes call gout the rich man's disease because the diet of a wealthy man of lots of beef and wine and shellfish and things like that, eat more expensive foods. People who eat like that, gout would be a common thing they would have to deal with. But gout can affect people who aren't rich as well. Okay. So, all right, we're done, guys. We got through and we're finished, and we're going to be doing this in one half of the week, and then I'm going to start on muscle physiology next half. Okay. So, guys, I'll see you in the next one.